Hello, this is Kim Jong-il. We are going to cover the topic U55 L55 Extraction Treatment. For the first case, there is a patient with anterior crowding and protrusive lips. The condition of this patient is not too bad on the E-line. A 21-year-old adult patient with protrusive lips. There is some crowding in the anterior teeth. The anterior teeth are slightly protruded. The third molars have been extracted. A slight crowding is observed in the anterior part of the upper and lower. In particular, this patient does not have severe asymmetry from the frontal view. However, there is a slight asymmetry in the chin, especially the nasal septum is deviated severely. If you look at the antegonial notch, you can see that the part on the right is placed more and more upwards. Let's look at the occlusal surfaces of the upper and lower. In the upper, there is a slight crowding, and in the lower, there is a U-shaped arch. Another thing is that tooth number 25 is rotated by 90 degrees. Let's look at the canine and molar relationship. It has a class 1 canine relationship. In the tooth 20s, tooth number 25 is rotated, so it shows a class 3 aspect. The tooth number 43 shows a slight gingival recession. Let's look at this patient. Since AB to mandibular plane angle is 70.5 and ANS are located low, palatal plane will have a positive value, so it becomes 74, 70.5 plus 3.5. A point is located anteriorly, so it has a negative value. APDI is 81.5 and CF is 155.5. In other words, it is class 1 low angle. There is no big problem in the anteroposterior dimension, and the face protrudes slightly. It didn't protrude so badly on the E-line. It is class 1 low angle in the skeleton of the patient. FMA is 31 degrees. It is large. U1 to lip line is 6 mm, over-erupted, and the steep UOP is shown. U1 to FH is 105 and normal value is 114 degrees. It is also inclined to the lingual side. MPA is 94, normal. IIA is 128 and lips appear slight protrusion. Let's look at the problem list for this patient. 1. There are protrusive lips. Extraction is necessary. 2. Combination factor is large. If possible, it should go with non-extraction. 3. The upper central incisors has a normal value and is inclined to the lingual side and is over-erupted. Intrusion is necessary, and if possible, non-extraction would be better. 4. U1 to FH is 105 degrees on the upper incisors. If possible, it is better to treat it with non-extraction. 5. It has a U-shaped arch form. In this case, the lower second premolar would be extracted. 6. Tooth number 25 is rotated. You can derotate, or if extraction is decided, you would be able to extract tooth number 25. However, the problem is that if the patient is treated with non-extraction, the patient would complain about the protrusive lips. This is not easy to solve. There is also anterior crowding at this point. There is a possibility that the anterior teeth would be inclined to the labial side more and more. What would happen if the premolar is extracted? The combination factor is large. Bite will deepen. Interincisal angle is 128. Large. U1 to FH is 105, and it is likely for the lingual inclination to be worse. Let's look at this patient's PEG index. Overjet is 2 mm, APDI is 82, canine key and molar key is 0 mm, POP is 14 degrees, and interincisal angle is 128 degrees. It is judged to be the second premolar extraction case. In this patient, the problem is that U1 to FH would worsen when U44, L55 extracted. Interincisal angle would worsen. The tooth number 25 should be rotated again. There is a possibility that the upper anterior teeth would be extruded. On the other hand, in the second premolar extraction, it would not be easy for the extraction space to be closed. Which teeth is best to extract? The asymmetry will be explained to the patient first, and the possible treatment plan would be narrowed down to two cases, such as the maxillary first premolar and the mandibular second premolar extraction or the second premolar extraction. In the upper second premolar extraction case, it is necessary to check whether it is sinus pneumatized or not. It would be better for this patient to extract the upper and lower second premolars. In the second premolar extraction cases, what should we do? As such, the lower second premolar extraction, an open coil spring is used without appliances attaching to the lower canine area. The appliances are not attached to the upper canine area at the beginning of the treatment, and an open coil spring is used on the upper canine area. The second thing to consider is whether the upper first premolar should be moved posteriorly first or the lower first premolar should be moved posteriorly first. It is recommended that the upper first premolar is moved posteriorly. First, an open coil spring should be used on the upper canine area. Then, the extraction space is closed. Then, the appliances are attached to the second molars and finish. There is also crowding in the upper tooth numbered 12. The appliance is attached to tooth numbered 12 later. The appliance is attached to tooth number 1, 4, and 6 among 10s, and to tooth number 1, 2, 4, and 6 among 20s. At the beginning of the treatment, Worstry Niti would be used. The following month, the OCS would be made on the 016 SS first, and the first upper premolar will be moved posteriorly first. At the same time, you can align the lower 4 incisors. Then, the crowded canine and lateral incisors are leveled, and a combination loop is used in the upper. An ideal arch with hook is used in the lower to close the extraction space. Even at this time, TPA or mini screws are not used in the maxilla. And once the space is closed, the appliances will be attached to the upper and lower second molar area. After leveling, MIA would be applied in the upper and lower. Short Class 2. Elastics is used from the upper second loop to the lower third loop of the MIOs. Then the treatment is over. You could realize that the treatment process is simple. We will be able to get a good Class 1 canine relationship and a good profile. There are panoramas of before and after treatment. PA before treatment and PA after treatment. The patient can close their lips more comfortably. Especially in PA, you should check for nasal septum deviation and otolaryngologic diseases. For this patient, the combination factor does not change. Combination factor was 156, by the way. It is now 157. 156 does not go to 150. U1 to FH was 105. It is now 104 degrees. It did not worsen. L1 to MP is 87 degrees. IIA is 138, which is in the 130s. They are well maintained. POP became more and more flat. We wanted the upper and lower incisors to move backward a little, and the posterior teeth to move forward a lot. To do this, the second premolars of upper and lower were extracted. You can see how the teeth have moved in such a condition. As the POP is flattened, the mandibular chin is moved a little forward and its aesthetics is maintained. When looking at the upper anterior teeth, the over-erupted upper anterior teeth is slightly intruded. In this case, by strategic leveling without using mini screws and close the extraction space with a combination loop on the maxilla. And in the mandible, Mesially inclined teeth are moved forward and being uprighted. Let's look at the profile photo. Of course, the profile before treatment wasn't too bad. But after treatment, you can see that the profile is much better. In other words, we can have a better profile by moving the anterior teeth a little backwards, moving posterior teeth forward, and then uprighting them. Basically, in what cases is the second premolar's extraction mainly done? Mainly when the incisors are lingually inclined or they have normal values. In other words, it has a class 1 skeleton, interincisal angle is over 120, which means around 130 degrees. There would be a slight anterior crowding. This is mainly done if it has a class 1 molar relationship. In addition, the second premolars can be extracted when it has class 3 high-angle skeletal pattern and interincisal angle is low, which is class 3 malocclusion. Once again, the process of U55, L55 extraction treatment is similar to the lower second premolar extraction process. So, the important thing is that the upper first premolar must first be moved posteriorly. Appliances are attached to the upper and lower canines, and the combination loop or ideal arch with hook is used to the maxillary, and ideal arch with hook is used to close the extraction space in the mandible. Then, appliances are extended to the upper and lower second molars. Do finish. Thank you for watching.